طيب اوكي. Welcome everyone وشكرا لكم على انضمامكم لنا الليلة. Thank you so much for joining us. بنعتذر مرة تانية على التأخير في البداية. Welcome to our fifth session of the Jazeera Rural Primary Care Echo. The general outlines of the session حقتنا بنبدأ زي welcoming and introductions. So إذا ممكن كلكم introduce yourselves in the chat, let us know a little bit about you. حنمر على السيشن reminder سريع، بعد ذاك حنبدأ didactic presentation حقتنا اللي هي حتكون about patient stabilization. في الآخر حيكون عندنا ال case based discussion. A few housekeeping reminders. زي كل مرة discussion makes these sessions work best. Please feel free to دايما إذا عندكم أي comments أو أسئلة share them in the chat or raise your hand and open the microphone وتكلموا أسألوها. We love to see your faces, so please open your cameras. النت بيسمح. Please stay muted unless you are speaking. And السيشنز دي كلها بتكون recorded وحنرسل لكم اللينك حقت الريكوردينج في الريكاب ايميل بيجيكم بعد نهاية السيشن. البرزنتيشن حيكون موجود في منصة ايكو. Before we start, we'd also like to thank the participants in today's session, the University of Nebraska Medical Center for their support, the Global Echo team and Echo India team for their continuous support with our program, الفاكولتي من جامعة الجزيرة، دكتورة عبير، بروف ماجدة، بروف سلوى السنوسي، وطلبة جامعة الجزيرة الأجلاء، our other guests who are joining us today. For now, I'd like to start our didactic presentation. هيبدأها معانا دكتور بشير السنوسي. دكتور بشير, you can take the floor.
طيب السلام عليكم ورحمة الله، كيف حالكم؟ إن شاء الله طيبين. بشير كمال الدين حامد السنوسي. consultant physician, consultant intensivist. Actually, we are missing our colleagues from emergency specialty. We have Dr. Mahiddin, he is an emergency physician. Just he was pulled in another presentation, so he may join us at any time, and he will take over the presentation. But I will start. Meanwhile, he might join us. So, firstly, welcome for the team, and I'm happy to join Echo sessions. It's an honor for me to start presenting. So, based on the topics of the presentation today, we are about to discuss the stabilization of critical ill patient. So I don't know if possible to share my screen or we'll go with your presentation.
You could share your screen if you want to. It won't be a problem.
Yes, please.
Okay.
So you need to edit first, then I will share my screen.
Okay. You can try doing it now.
Okay. Yes. Okay. Are you?
Yes, we can see your screen, Dr. Bashir.
Yes. So, stabilization of critically ill patients. So generally, before we go more, I think you selected an important topic, which for any medical practitioner need to know the basics of resuscitation and stabilization, as it is the first priority for any medical intervention. I think before we go to stabilization, we need first to recognize, then prioritize, then stabilize. So I think if we went through these steps, it will be much easier for us. For recognition, we have to know that the need for resuscitation may announce itself very obviously, and it will be very clear, but sometimes it will be very subtle, and you need to look for it. So to be able to recognize the life-threatening condition, you need to recognize the abnormal vital signs, and you need to be able to recognize when a patient is unstable and requiring immediate intervention. And you have to know how to perform a systematic approach for assessment which usually we refer to for primary assessment or primary survey for critically ill patient or injured patient. So I will just give you like a small scenario, then we can discuss based on this. If we have a 65-year-old patient brought to the emergency department after road traffic accident, he is bleeding from multiple cut wounds in the upper limbs, in addition to severe swelling, which is possible hematoma in the right thigh. His last reading of blood pressure was 80/50. What do you think the most important step in the management of this patient? So I'm just allowing our colleagues in the floor to participate.
I think first we should correct the blood pressure because it's pretty low and it can cause serious complications.
So you think 80/50 blood pressure is very low and we need to
Yes.
correct this. Okay. Anyone had another idea?
Yeah, I believe we should establish IV access very quickly because the patient is crashing and his veins might collapse very soon. So we need to give him fluids, and so we need IV access as soon as possible.
So IV access and IV fluid to be the first intervention. Anyone have a different opinion?
I believe you have this one.
I think we should stop the bleeding.
You think you should stop the bleeding? Okay, so not to lose more pressure. Okay. It's an open discussion, no right, no wrong up to now. So any suggestion is accepted.
We also have two answers in the chat, Dr. Bashir. Ahmed Hassan says we should apply the ABCD approach, and Fatma Hassan says we should stop the bleeding.
Yeah. So thank you for Ala, the first one. So generally, as a golden rule, you have to treat first. That kills first. Okay. Do not have a different approach, and everyone at the emergency department is looking at different from a different view. Everyone is starting a different set of intervention. A systematic way of assessment and management of critically ill patient is adopted, and it is internationally adopted because usually in the emergency department it is a teamwork. So if the team have the same background and the same way of intervention, the coordination will be much easier. So we need a systematic approach, as I mentioned, which is internationally the ABCD approach. The goal is to identify the life-threatening condition rapidly and ensure the airways are open, breathing is okay, and circulation is okay. So what do you think? Which will kill this patient first? Is it the bleeding or obstructed airway?
It would more likely be an obstructed airway, I think.
Yeah, but we were distracted by the hematomas, the bleeding, that which is ongoing. Everyone will step in. I will try to control the bleeding. I will insert the line. I will give IV fluids, but we will forget about things that may kill the patient before we establish the line or we give the IV fluids or blood transfusion. So this is why the ABCD approach came. It came to solve this issue and to set the priorities. As we mentioned, we need to recognize, all of you recognize this is a critically ill patient, but then we need to prioritize our intervention. The priority here goes for the airway rather than it goes to the circulation. In addition to the systematic ABCD approach, usually these things are not following each other, but usually combined, and we do it at the same time. There is what is called the focused history, which is we refer to like sample history. It's a very short, directly to detect the problem of the patient, rather than going for the detailed history that we got with the medical department in form of detailed history. We go for very focused history, which is called sample history. We go just for signs and symptoms, allergies, medication, past medical history, last oral intake, and major events. This should be combined with the ABCD approach. So we are assessing at the same time we are taking focus history if we need to do. The goal of this sample history is to rapidly gather history critical to the management of the acutely ill patient. We are not looking for the socioeconomic status. We are not looking for a lot of details and systemic review as we do regularly, but we are looking for just focus, looking for major areas for hints that can help us to provide a high priority intervention. So priorities, treat first what kills first. So we inform if intervention, we do the most critical intervention first, and we fix problem before moving on. Okay. Generally, in form of priorities, also we can divide our patient into CUPS classes, which is critical, unstable, potentially unstable, or stable patient. So if you are not dealing with a single patient, if you are dealing with a mass trauma or multiple patient or car accident, sometimes the priority is not to which intervention for the same patient, but for which patient to start serving before the others. So the critical or unstable or potentially stable or stable patient. There's also well-known classification for the critical, those who are needing for life sustaining ventilatory or circulatory support, potential who are, for example, comatose and unresponsive, the stable who have minor injuries or hemodynamically they are fine and no need for urgent intervention. After that, we go for stabilization. And our goal in the first 5 minutes of resuscitation is to establish resuscitation that effectively carried out and to identify immediate life threats and initiate stabilizing intervention. During our assessment, we should not miss cardiac arrest because sometimes it is missed when the patient are unresponsive. We go for more neurological assessment while patient might be on cardiac arrest. And we have to be able to detect the airway related signs such as change of voice, stridors, and mishandling of secretion. And we usually go for the blood pressure as a proxy for tissue perfusion, while it is not the case usually. And the most reliable indicator is on end organ perfusion. So what I would like to tell you here that sometimes we find a critically ill patient who is trying to compensate. Sometimes you may find the blood pressure is okay, but the patient is not okay. Do not misinterpret the compensatory mechanism of the patient and to judge on the patient that they are fine and they are not that critical. For the blood pressure, for example, to be low in a shock patient, you need to exhaust the compensation based on heart rate. You need to exhaust the compensation based on contractility. Some organs will be deprived from perfusion, like the kidneys, to maintain the blood pressure. All this might look not affected if you just measure the blood pressure, but if you had a look for other parameters rather than the blood pressure, so you can figure out if the patient is critically ill or not, or he is just compensating or not. So before we go to the ABCD approach, sometimes you need to know time matters, that sometimes you need to stay and stabilize, and sometimes you need to transfer urgently. It's very established that stabilization before transfer is the right thing. Stabilization is the first step. But sometimes in some critical ill patient, you may not be able to add value with your stabilization. And for these patients, you need to refer as urgent as possible. For example, for a patient with severe chest pain, profuse sweating, most likely he's going into myocardial infarction. Apart from giving aspirin, if you have it or not, you will not be able to add a lot if his circulation is maintained, and it's better for him to be referred. Sometimes if you have a patient with fracture, it's most valuable to immobilize this fracture before moving the patient with the ambulance, because you will do the most appropriate thing in the scene or in the place before transferring the patient. So usually we go for stabilization before referral, but do not delay patient referral with a lot of mitigated procedures before you go for transfer. So generally, when we are assessing a critically ill patient, we assess. If we find an issue, we manage it and we monitor. So assess, manage, and monitor is the main approach that we'll go and we'll follow at each step. Before I go for the ABCD approach, I will stop here, allow you space if you have any question or any comment.
If I may, I'd like to ask for a little more explanation on the sample history. If you could go over it again quickly.
Yes. Okay. So for a patient who is critically ill, you will not have enough time to ask him name, age, gender, from where, which tribe. You will not have all this time for details. You go for the main complaint, for allergies, medication if he's using any past medical history, events if are major, and I will ask the floor why last oral intake matters. Why we ask about the last oral intake. شباب ليه بنسأل الناس دي من اللاست اورال انتيك؟
عشان اشوف لو في obstruction في تراك بتاع esophagus مثلا.
Toxic materials.
Toxic materials. Okay.
We also have a hand up, Mohammed Dafallah. Go ahead.
السلام عليكم.
وعليكم السلام.
طيب أنا I ask يعني ممكن أنا أكون خدت في الانترفنشن بتاعي أنا مثلا عايز أدخلهم، ممكن أحتاج لأن أدخل أوبريشن طوالي immediately، فأنا على أساس إنه to assess the time because of الأنستيزيا والحاجات دي.
ممتاز. بغض النظر عن الانستيزيا، انت جنرال قد تحتاج تعمل انتيوبيشن للعيان. الحاله دي قد اذا العيان فول ستومك ولا كده ممكن يحصل لك regurgitation واسبيريشن. You have to be careful من الحاجه. In addition to the points mentioned by our colleagues at the possible of toxic materials, لكن the major issue is the risk of aspiration also. تاني يا شباب، في زول عنده سؤال؟ طيب عرفنا كيف نفرق بين العيان maintaining his circulation through compensation والعيان الكويس. الاثنين ممكن يكون البلد بريشر بتاعهم تمام، يمكن الاثنين يكون البلد بريشر 100/70، لكن منو الكويس ومنو ممكن يكون this is just compensation. في زول عنده سؤال ولا نمشي زيادة؟
ما عندنا أسئلة فوق ده.
تمام. طيب before you start assessing any critically ill patient, the first step is to ensure your safety. So if you are safe, you can approach the patient. If you are not safe, you will just add on more victims and more patients. So safety first. The safety have different what can I say? So the safety is not just about the scene. Safety may be in form of your PPE, in form of dragging the patient out of the main road, and so. So if there is for example, a road traffic accident, you will not be able to intervene in the middle of the road. You need to drag the patient outside of the road, or you need to stop the movement, or you need to secure a safe place for you to be able to support this patient. If you are dealing with a patient who is ill, he's bleeding, part of your safety will be like having your gloves on or putting on a surgical gown or something. If you are dealing, for example, with a patient with COVID, you need to have, for example, the standard personal protective equipment for this disease. Then you will be safe and you will be able to support the patient or intervene rather than putting yourself in a risk. So we'll end with 2 patients rather than 1 patient. So these are different scenarios for safety consideration, scene safety, or using PPEs, sometimes cleaning and decontamination, and sometimes asking for help, specifically for multiple patients, is going to be a good thing. For example, a person walks into your house, he's vomiting and he's bleeding from mouth, and he complains of abdominal pain. What do you think the needed safely approach for this patient? How you approach this patient safely?
I will need to put on glove first before contacting with the patient.
Put on ليش ما سمعتها؟
Gloves.
Gloves.
Hands.
تمام. تاني في زول عنده إضافة يا شباب؟
If we are suspecting إنه البيشنت جاي من a farm area and may have been exposed to organophosphorus from the farm area pesticides, we would need to put on protective clothing لنفسنا and take off the patient's clothes to decontaminate him.
تمام. Most likely for this patient is vomiting of blood, so gloves is a good option. Do you need to have a surgical gown? Do you need to get some boots? Or just gloves is enough?
A surgical gown and boots would be useful to protect ourselves from the patient's vomitus.
Yes. Okay. So again, what kills first should be assessed and treated first, and we go for assess, manage, and monitor. So this is the ABCD approach, which is the common approach that we are using for assessment of any critically ill patient. Actually, it is ABC, or it is called CABCs because the cervical spine is considered part of the A. So the A is for airway with cervical spine immobilization, and B for breathing plus oxygen if needed, C for circulation with bleeding control and IV fluid, D for disability, and E for exposure. So for the airway, what do you think the best way for assessment for airway? What will be the best way for airway assessment?
Opening the mouth.
Okay. Any other idea?
Listening to breathing sound.
More ideas?
Tilting the
Yes.
patient's head backwards and lifting the chin so that we can see and feel around in the patient's mouth for anything.
Okay. More simple than this?
Chest movement.
More simple? I think the most simple way for assessment of airway is to talk to the patient. صح؟ كان غلطان قولوا لي. If the patient is talking, his airway is patent, and that is done. If the patient is not talking, then you can go for what you mentioned in form of detailed assessment. We are going for ABC, and okay. So let us go for the A. If the patient can talk normally, his airway is open, then you go directly to the B. If he cannot talk, then you go for look, listen, and feel, as you mentioned. So you open the mouth of the patient, you look for possible obstruction by foreign body, by secretion, you look at the chest movement, you listen for breathing sound, you feel. So this is how you go for the airway. Listen for abnormal sounds, listen for fluid in the airway, most likely are secretions, look for foreign body, swelling around the airway, and check if the patient is able to swallow his saliva. So if you go for the A, for the ABC, the simple way is just talk to the patient. If he is talking normally, you can go for B. If the patient is unconscious and not breathing normally, and if no concern of trauma. So this will come to the second step. If it depends what type of airway maneuver you will use to open the airway. Either you go for head tilt and chin lift, or if a possibility of cervical trauma, you go for jaw thrust. Because when we do head tilt, there will be like overextension of the spine. And if there is a fracture of the spine, this may cut the cord and you will be in more complicated situation. So if no concern of trauma to the cervical spine, you go for head tilt and chin lift. And if trauma is suspected, you maintain the mobilization of the spine, immobilization of the spine, and you go for only jaw thrust maneuver. If you manage to open the airway and you got the breathing sounds clear, you assess and you manage. For the airway, sometimes you need to keep, you will not be able to monitor apart from hearing the gurgling sounds and so, but you need to add like adjunct airway in form of oropharyngeal airway or nasopharyngeal airway, depending on the gag reflex of the patient, if he is able to tolerate the oropharyngeal airway. If a patient have a good gag and cough reflex, he may not be able to tolerate it, so we'll go for the nasopharyngeal airway. I have some photos for this which we can share, which I can show you. So sometimes for patients who are choking, there are separate maneuvers. It depends on the age of the patient that we can use, but I will not go into details for this, like the abdominal thrust down and back blows. If secretions are present, we go for suction, or if suction is not available, through gauze, we can wipe and clean, and we can keep the patient into recovery position or the left lateral position after maintaining the airway. If the patient have swelling, hives, stridor, there is a possibility here of airway obstruction secondary to edema, which most likely allergic and anaphylactic reaction. And then part of the intervention for the airway here will be intramuscular adrenaline, because you need to manage the airway before going to B or C. You have to manage the issue of the airway. If a possibility of anaphylaxis, adrenaline injection is going to be part of the management for the airway. So after the B, so this is a Philadelphia cervical collar for stabilization of the cervical spine. And if you can see here, these are the different types of airway. These are the oropharyngeal airway, and this one is the nasopharyngeal airway. If you notice, this is a very plastic rubber, which is very soft. It can be introduced like an NG tube, and so it does not trigger a lot of cough and gag for the patient. And this one is a little bit harder, and it can be used for comatose patients who do not have intact cough and gag reflex or male gag reflex. Have you ever used any of these؟ شباب في زول استخدم واحد من الاثنين دول قبل كده، سواء الاوروفارنجيال ولا النيزوفارنجيال؟ طيب لاقوكم؟
شفتهم قبل كده بس ما حصلت استعملهم.
لا شفتوهم في نفسهم لايف كده حيين؟
لا بس كان عندنا كورس بتاع basic skills شفناهم as subjects ما استعملناهم قبل كده.
تمام. الغريب انهم very simple و very cheap، لكن المفروض يكونوا available والله في every emergency department. Unfortunately بالذات النيزوفارنجيال airway ما قاعدين نلقاه كثير، لكن الاوروفارنجيال متوفر. لو لاحظتوا عنده different colors. We used to size it، يعني المفروض يكون المقاس بتاعه المناسب من السكند incisor في التوس لحد الانجل of the mouth of the mandible. ده الطول الخارجي المناسب من هنا لهنا. If we manage to get the appropriate size, we just introduce it into its own technique for introduction. Nasopharyngeal is very simple، لكن بس مشكلته الافيلابيلتي، يعني ما متوفر كثير. Any question for the airway?
I have a question. لو في obstruction, how do we ensure إن إحنا نقوم لما نكون بنحاول ندخل في الديفايس بتاع الأيروي ونقوم ندخل الحاجة زيادة لجوا في النص؟
Good question. رأيكم شنو يا شباب؟ قال هو شايف انه لو جه يدخل الاوروفارنجيال ايرواي ده مثلا، ممكن اذا في حاجه عامله obstruction حيدخلها حيلزها لجوا زياده.
That is why we're supposed to check before inserting it. إنه إذا في حاجة عاملة obstruction, we're supposed to take it out before inserting it.
واحده من الستيب اللي قبل المانجمنت مع الانترودكشن اوف ذا ايروي ده بارت في المانجمنت، صح؟ نحن اول حاجه بالاسس، صح؟ في الاسسمنت we open the mouth and we have a look. لو ما في foreign body, if there is a foreign body we remove. Otherwise بيكون already we pass this point. When we come for introduction of the oropharyngeal airway it will be okay.
ممتاز. السلام عليكم دكتور بشير.
اهلين اهلين يا دكتوره، كيف
الله
اخبارك؟
يخليك دكتور عبيد، الله يديك العافيه. انا متكيفه شديد يا دكتور بشير، بس تعليقي على ما اعتقد دي مهاب هو في القاعه. فتعرف يا دكتور بشير هم الطلبه الستودنت اللي عندنا طبعا الليفل بتاعهم، في ناس دخلوا كلاركشيب وفي ناس لسه ما دخلوا كلاركشيب. فالمسؤوليتهم دي يعني حاجه سمحه شديد. ليه؟ لانه في ناس لسه يعني عرفت الحاجات دي ما بيكونوا هاضمينها زي الناس التانيين. فسؤال جميل انا عجبني، وبس دايره اشجعهم هم عشان شنو يسالوا ويعرفوا، وكل ما يعرفوا الحاجات دي اهم حاجه في how to stabilize, how to save a life. دي اهم حاجه لنا، يعني هم يكونوا عارفينها وكل مره حيدربوا فيها، كل مره حيدربوا. فانا عايزاهم يلا، وشكرا لهم، انا عايزاهم يشجعوا زياده وما تخجلوا، تسالوا الليله دكتور بشير ده. دي اهم حاجات في الطب، how to save a life. شكرا يا دكتور بشير، معلش للمقاطعه.
تسلمي لنا. ويلكم يا دكتوره، ويلكم يا شباب. انا ذاتي يعني ما فورمال شديد، يعني انا ذاتي زول فيري فريندلي ويلكم. يعني احنا it's a discussion اكثر من انه I'm trying to give a lot of information.
ايوه شكرا، الله يحفظك.
طبعا actually الحاجات دي practically بتكون اجمل من theoretically لما تكون hands on ونجيب الحاجات دي يعني تشوفوها. لكن we can imagine a process واي زول عنده سؤال حاسس انه في حاجه فيها gap just step in unmute and just start طوالي اسال ما في مشكله. بعد التشجيع ده ما في زول عنده سؤال ثاني؟
طيب ممكن تكون inserting the airway device تكون guided by imaging like X-ray or CT عشان ensure in في ال right path.
شكرا يا دكتور على السؤال والله. It's a nice question. ال airway adjuncts ديل كلهم بتراوحوا من الأوروفارينجيال النيزوفارينجيال اللارنجيال ماسك اللي هو ال LMA، بعد ذاك بيجي الاندوتراكيال تيوب والتايبس بتاعتها المختلفة. هم مقسومين لقسمين تقريبا، اسمها سوبراجلوتيك. كل الديفايسز اللي بتيجي فوق للإبيجلوتس كلها التكنيكس بتاعتها بلاين. تصميم ذاته مصمم مع الاناتومي بتاع الماوس والنوز والاوروفارينكس، انك you just insert it بتكنيك very simple. You do not need visualization. You can just go ahead and sometimes we use some guidance باللارنجوسكوب او الفيديو اسيستد او كده للبوست يعني للاذر advanced airways زي الاندوتراكيال تيوب. لكن لكل الحاجات دي you just follow the anatomy and it is blind techniques. It does not need any form of guidance. والguidance usually هنا ما بيكون X-ray ولا CT، بيكون فيديو لايف بتكون شايفه معك وانت شايف روحك ماشي وين، لانه الCT والX-ray والكده هتعمله بعد ما تخلص. you may need to confirm ده في الاندوتراكيال تيوب، ولكن ما بكون براكتيكال انك تاخد ايروي تودي العيان يعمل صوره ويجي راجع، قد يكون الايروي بتاعك غلط يقول له ذا بيشنت himself. تمام. ديل اوكي. Let us go for the B, breathing. For breathing you need to look, listen and feel to see if the patient is breathing. You assess if the breathing is very fast or very slow. Very slow breathing is not okay. Very shallow breathing is not okay. Tachypnea is not a good sign, and bradypnea is more serious sign. So you look for features of increased work of breathing, using of accessory muscle, chest indrawing, nasal flaring, abnormal chest wall movement. كل الحاجات دي you can just observe إنه this pattern of breathing is abnormal. If the pattern of breathing is abnormal, this is a danger sign. You need to listen for abnormal breathing sound. Sometimes they are audible. You can hear wheeze sometimes without cystoscope, and sometimes with the aid of your cystoscope. تمام. So you do for very quick في البي والله بنعمل قريب من الchest examination حقنا. We go quickly to assess the trachea if it is on normal side or shifted to one side. You just quickly for percussion for dullness, and so you can see if there is a possibility of pleural effusion or hemothorax in case of trauma patient, and you can check if hyperresonant the possibility of tension pneumothorax. I'm not sure if you are familiar with الحاجات دي ولا لسه it is too early وانتوا يا دوب داخلين الكلاس لسه؟
لا فاميليار لا.
كلها سمعنا بها الحاجة.
تمام. طيب سريع كده pleural effusion يكون عندنا فلويد قاعده في البلورال كافيتي يوجوالي في one side او في two sides، حتقلل المساحه اللي بتتحرك فيها اللنج، فبالتالي البريسنج بتاع البيشن بيكون صعب، ولانه في فلويد تحت الريبس لما نعمل البركشن بتكون فيري ضر. نفس الحاجه دي بتحصل في التروما، لكن الفلويد اللي بيكون قاعد ده بيكون بلد، لانه غالبا التروما دي جات حاجه اكيوت وحصل للزول بليدنج. في بعض الاحيان بيدخل اير بدل الفلويد وبدل البلد، وده بيكون بنقول عليه نيمو ثوركس. ولما تكون سيفير نيمو ثوركس وافكتنج الفاسيلز وعامله شيفتنج للاذر سايدز وافكتنج السيركوليشن والبريشر فيها ماشي زايد، بنقول عليها تنشن نيمو ثوركس. فدير كلهم حاجات they can affect the breathing، لكن كلهم حاجات easy to manage. طيب how to manage breathing، خلينا نسمع منكم how to manage breathing. and I will mute لحد ما نشوف انتوا هتقولوا شنو.
Oxygen devices. Gas
ventilators.
CPR.
It seems إنه الدكتور بشير dropped off. ممكن يكون عنده مشكلة شبكة. Until he joins back برضه بحب أرحب بدكتور ندى فضل ودكتور وائل نوري عميد كلية الطب جامعة الجزيرة. Thank you so much for joining us. دكتور وائل نوري, if you'd also like to give us a word. Oh, I see إنه دكتورة ضحى جلال برضه joined us. Thank you for joining us, دكتورة ضحى. If you would like to continue from where Dr. Bashir left, you are also welcome until he joins back. Yes, Howley, try and mute and then unmute yourself again. Maybe that will help.
I could do that. Wait, just
now it's working fine.
Okay. Can you hear me now?
Yes, clear.
Okay. I was saying safety comes first. It's a very important principle in the emergency department that we have to be safe for our patients to be safe. If I'm not safe, this could translate to my patient, the patient in front of me not being safe. I will not be able to provide for the patient. And if I'm not safe, my subsequent patients will not find me and thus they will not be safe. And this could simply mean just donning personal protective equipment, or in toxicological emergencies, it could mean decontaminating the patient, removing the patient's clothes, and so on and so forth. And could also mean chemical restraint, which is basically trying to calm down the patient who is agitated with drugs. After I ensure that I'm safe to approach the patient and my team is safe, then I would call for help. And this is another critical concept in emergency medicine, because emergency medicine stabilization is a team sport. It's not a one-man show, and this is one of the principles that make emergency medicine special. We don't do things at an individual basis. It's a team. As I said, it's a team sport. So I have to make sure of three things. I have to make sure that the patient is in the right place. For example, in an area where there is a monitored bed, where there is an oxygen source, and with the right equipment, everything I need should be near me at hand's reach. وكل ما نمشي في البرزنتيشن اللي قدام هنعرف what are the equipments that we use in emergency department.
معلش دكتورة ضحى, please. Can you hear me? Yes, I apologize.
Yes.
You try muting and unmuting yourself تاني. أصوات تاني ما بيشخص كده. متأسف. No, it's still not
I think
working.
the problem is in the microphone. لو بتقدري تفصل الميكروفون بتاعك توصليه تاني.
I could do that.
Or if you're using a Bluetooth AirPods or something, unconnect them and reconnect them again.
كده, can you hear me?
I think it's a little better. صح يا شباب؟
Yeah.
يا أحسن شوية.
كده أفضل.
Yes, that's better.
Okay. So I was saying, by calling for help, I have to achieve three things. I have to make sure that my patient is in the right place, where there are the right equipments and the right people are here. If they are not here, at least I should have them notified to come as soon as possible. After I have those down, that I'm safe and the people that I need are with me, I should start the sequence of the primary survey or the sequence of ED, emergency department stabilization. And it's a mnemonic. It's the A, B, C, D. I don't go from, I start with A, I don't go to B unless something with A, or I make sure that A doesn't need anything to be
Dr.
done.
Duha, sorry, it's starting to happen again.
Let me try connecting and connecting again.
Okay, that won't be a problem.
Just a minute.
This meeting is being recorded.
So we were saying, the primary survey, or how I stabilize patients in the emergency department, we can think of it as a sequence. We don't go from one component to another unless I'm happy with the preceding component. And the ABCD approach is like a mental checklist that we utilize in the emergency department to make sure that we are through and thorough with our assessment and management of our patients.
Your voice seems to have cut off, Dr. Duha. سمعنا? It seems she dropped off again. Dr. Duha, I see you joined again. Are you with us?
Yes.
Okay. I'd also like to remind or tell you that we have about 15 minutes left for the session. So I apologize and would have to ask you if you could go through it a little faster. Sorry.
Yes, of course.
Okay.
Okay. We start with the A, and A for airway. And with the airway, there's one question that we have to ask ourselves and answer. And it's whether there's airway compromise or not. If there is airway compromise, what's wrong?
Dr. Duha,
think the assistant.
Dr. Duha, if you have
I don't think it's an issue with the
the
microphone.
voice was not clear.
Is it not clear ولا الشبكة؟
Maybe it's a connectivity problem. If you
Yes.
have another, no, it's
Yeah.
هو بيقطع كثير.
Okay. Let me try and do something about it. I'm not sure.
No, it's working well now.
Is my voice
Try to say something.
Yes,
It's happening again.
if it is, we can go on.
The problem seems to still be there, Dr. Duha. الصوت لسه مقطع شديد كده. في حالة try stepping back from the microphone just a little bit.
Okay. Is it better now?
يعني بيمشي وبيجي كده. Okay, try continuing for now.
Okay. We were saying the most simple way to assess the airway is to ask a patient a question. And if they respond with a clear voice, I can check 3 boxes in my assessment about the airway. And it's that the airway is patent, because if it was obstructed, then the patient wouldn't be able to produce clear voice. And the other one is that the musculature of the upper airway is functioning properly for the patient to produce voice, and that they are maintaining well. So the airway is if they can respond, that the airway is patent, protected, and I'm happy about the GCS. If they can't respond, or if they respond in, for example, a hoarse voice or a muffled voice, I then proceed to do a detailed assessment about the airway. I would look, I would listen, and I would feel. Look inside the tongue and inside the mouth. I look for foreign bodies, secretions, vomitus, blood, anything that is not supposed to be in the oropharynx. I would listen for the sounds that are indicative of airway compromise, which are snoring and gurgling, and stridor. And with stridor, I'd be very terrified because stridor signifies severe airway obstruction. And I'd feel the neck for masses, for hematomas, or for subcutaneous emphysema. Which means there is disruption in air-filled structures like the larynx, the trachea, or the lung itself. One caveat here is that if I'm happy with the assessment, maybe I did my assessment and I concluded that my airway is good. I have to make sure that it's going to be good for the next moments. Some conditions can cause progressive airway compromise, and I have to secure the airway before I lose it. For example, in conditions like epiglottitis and anaphylaxis. These conditions cause progressive airway compromise. By the moment I see the patient, the airway might be good and functional, but a few moments later I might lose it. So I have to develop a clinical sense or an intuitive picture about those patients. After I did my assessment of the airway, and if I have to manage the airway, there are temporizing measures. There are measures that I can do. They are quick and simple, yet very effective. And these are repositioning. We'll see the images, and I'll explain each one. And then there are the airway adjuncts. We'll see their pictures in the few slides, the upcoming few slides. And these are the oropharyngeal airways and the nasopharyngeal airways. They are very simple, yet very effective. And the problem with the airway could simply be that there are secretions in the airway. And by suctioning the airway, I could open it. ممكن نشوف السلايدز اللي بعديها to have an idea of what repositioning is. Here there are the three repositioning maneuvers, and these in A, the airway obstructed, as you can see here, by just flexing extending the head and flexing the neck, and this is the sniffing position or the head tilt position. I open the airway, I move the epiglottis away from the glottic opening, and the airway can flow unobstructed. I could tilt the head and elevate the chin, and this could provide further opening of the airway. And lastly, I could thrust the jaw upward and forward, as in the image number D. And here it provides you can clearly see that the airway is much more open now when I thrust the jaw open. So we have basically two maneuvers, and the third one is a combination of the first two. These are the head tilt chin lift, the jaw thrust, and the third one is all of them combined together. You can move on. This is the head tilt chin lift. And the other one, the one after this, is the jaw thrust. I believe the next slide has the oropharyngeal airway and the nasopharyngeal airway, and these are airway adjuncts that I can use to make sure that the airway is, the anatomy of the airway is patent. Move on. Yes. After I'm done with the airway, after I did what is supposed to be done, I moved to B, which is the breathing. And with each component of the ABCD approach, there is a question that I have to answer. With A, it was whether there was airway compromise or not. With B, it's whether the patient is in respiratory distress or not. Next slide. And in the assessment of breathing, I do the respiratory rate and the pattern of breathing. I check the oxygen saturation, and then I do a chest exam, a quick chest exam. I listen bilaterally, I percuss, and I palpate for chest expansion. And then I check the trachea and the jugular venous pulsation. These are the things that I have to do in the assessment. Before that, I have to make sure that the patient is actually breathing and is not apneic. If the patient is apneic, I should immediately provide assisted ventilations with bag mask ventilation. Next slide. And the management in the breathing component is according to the underlying etiology. For example, if it was tension pneumothorax, I could temporize the breathing system by doing a needed decompression or finger thoracostomy until I prepare my tube thoracostomy kit. For pulmonary edema, I could put the patient on CBAP or BiPAP, and these are the two forms of the non-invasive positive pressure ventilation. until I prepare my nitroglycerin drip. With asthma, it's the same thing. I could put the patient on non-invasive positive pressure ventilation plus oxygen until I prepare bronchodilators and steroids and so on and so forth. With pneumonia, I can put the patient on oxygen until I give them empirical antibiotics. With ARDS, I should immediately provide ventilatory support. And here you get an idea of the temporizing measures versus definitive management. There are things that I can do to temporize the situation to make it a little less worse until I proceed with the definitive management. And this is a recurring theme in the emergency department. This is what we do in the emergency department. Next slide. Devices, and each one has a letting flow rate and how much oxygen it delivers. That is the fraction of inspired oxygen. The Nordic breather mask and the bag valve mask can provide up to 100% fraction of inspired oxygen if they are done right. Next slide. Here, these are just a few concepts about the bag valve mask or bag mask ventilation. I have to be cognizant of the volume, the pressure, the rate, and I can use, with the bag valve mask, I can use the airway adjuncts that we talked about, the oropharyngeal airways and the nasopharyngeal airways. And I have to use the two-handed technique. Can you show the next slide? Yes, it's the CE maneuver. This is a single-handed technique, and this is the maneuver that is used mostly by the anesthesiologists. إحنا في the emergency department where situations are most likely more chaotic and hazardous than in the OR. We like to do the two-handed CE technique because this one can provide a much more harder and provide a good mask. So emergency department, we prefer the two-handed techniques. It's either the CE technique before C and E. I think it's clear. And there is another technique, which is the V8 technique or the thinner grip. And this one provides a much more better mask seal. Can move to the next slide. After I'm done with the breathing component of the primary survey, I move on to the circulation. And with the circulation, there is the question here is whether there is tissue hyperperfusion or not. And there are proxy items that can tell me that the patient is hyperperfused or not. And these are the blood pressure, the pulse rate, and the capillary refill time. Changes in these parameters can give me a clue about the perfusion status of the patient. Can move to the next slide. And mostly by hyperfusion we mean shock, but hyperfusion is a much specific term. And hyperfusion is either, you can think of it as a metaphor of the bone is the part of the lives are these are the muscles, the aorta and the deep veins, and the tank is where the blood is. It's either in the inferior vena cava or can leak into the abdomen, the pelvis, or the lungs. So you can think of it as either a pump problem, pipe problem, or tank problem. Move on to the next slide. Here, these are the categories of shock. Each category has specific hemodynamic changes and etiologies. For the sake of time, I think we can. The metaphor of bomb tank pipes explains it in a more intuitive way, and I don't have to go through all of the hemodynamic changes. You can go to the next slide. In the management portion of the circulation, I have to establish vascular access, whether it's an IV angiocatheter, an IV cannula. It has to be a wide bore, 18 gauge or bigger. I can do a central line or an intraosseous line. All of these are provided rapid management of circulation. I can give IV fluids if the situation calls for IV fluids or blood products. I can give vasopressors if the situation calls for it, and if there is, for example, tension pneumothorax that is affecting the circulation, causing an obstructive shock, I can do tube thoracostomy. Or if there is cardiac tamponade, the left ventricular contractility is affected by fluid around the heart, I could do pericardiocentesis. One concept that I want to emphasize here is the use of POCUS. It's a term short for point of care ultrasound in the management and assessment of the circulation component of the ABCD approach. زي ما قلت قبل, we can think of hyperperfusion in the metaphor of tank, pipes, and pump problems. And we can use the ultrasound to detect each of these problems. We can move to the next slide. Here, it's just an overview of how we use focus to assess shock patient. To the next slide, yes. And here we reach the D component of the ABCD approach, which is disability. And with the question with disability that I have to ask myself while I'm assessing the D component of the ABCD approach is, what is the neurological status of the patient? With the disability, I assess the GCS, the Glasgow Coma Scale. I assess the pupils, which are the mirrors of the brain, and I assess. I can move to the next slide. And I assess the random blood glucose. A helpful mnemonic that I use to remind myself to always check the random blood glucose with a primary survey is A, B, C, D, E, F, G. It's the ABCs plus don't ever forget glucose. It's very important because administering glucose to a hypoglycemic patient needs very quick results. And if I don't detect it, I don't management, I don't initiate the appropriate management, this could lead to catastrophic results. Can move to the next slide. And this is the last component of the ABCD approach, which is exposure. With this, I expose the skin of the patient to look for maybe it's a patient presenting with anaphylaxis, and I have to look for a specific thing that is causing the anaphylaxis for the patient. Maybe it's a bee sting. So exposing the skin of the patient is important. And it's part of the primary survey of ED patients. Another thing in the exposure is I have to check the temperature, preferably rectal temperature, or I can get a general sense of the temperature. If the patient is hyperthermic, I can initiate active cooling, or if the patient is hypothermic, I can initiate active cooling of the patient, active warming and active cooling. I think I mixed them. I think that's all for the stabilization of ED patients. Thank you for listening. Sorry for the inconvenience of the connectivity. If you have any questions, you can send them through and I can answer them if we have time, but I don't think we have time.
Yeah, it's okay. Thank
It's
you.
okay.
Thank you so much. Yeah. Thank you so much Dr. Duha for this amazing presentation. ويا شباب إذا عندكم أي أسئلة أنا هطلب من دكتور ضحى تدينا الإيميل حقها هو برضه دكتور بشير وبعد ذاك we can reach out في الريكاب إيميل هنرسل لكم ريكاب إيميل هيكون فيه الإيميلات حقاتهم if you want to ask any questions just in the interest of time يعني would that be okay دكتور ضحى؟
Yes, of course. I
Okay.
don't mind it.
Thank you so much. طيب moving on now, I'd just like to give you a quick reminder إنه السيشنز حقتنا زي ما عارفين قاعدة في الموقع بتاع اي ايكو فده اللينك حقنا للتسجيل بعدين هتلقوا السلايدز دي هتكون قاعدة في الموقع في ذات نفسه so if you want to register وبرضه هتلقوا هناك الكيس برزنتيشن هتكون موجودة براها والسيرتيفيكتس حقتكم بتظهر هناك. ده زي نموذج كده لل ريكاب ايميل اللي بنرسله بعد كل سيشن we apologize ان احنا اسفين عارفين انه اغلبيه الناس ما بيستعملوا الايميلات لكن المنصه deals only with emails ف as an example بيكون جايكم الريكاب ايميل كده زي ما شايفين بيكون قاعد فيه ريمايندر للسيشن الجاي وبرضه اللينك بتاع اليوتيوب للريكوردينج حق السيشن وبرضه تذكير تاني إنه if anyone wants to present case في أي session feel free to reach out to either me أمل أو فاطمة في الإيميلات حقاتنا الموجودة و we can work out how the case will be وممكن يعني نتناقش معاكم فيها ونجهزها معاكم إن شاء الله. بالنسبة للفيدباك أنا هسه هرسل لكم الفيدباك لينك في الشات لما تفتحوها وطبعا ممكن برضو تخشوا على الموقع في ذات نفسه تختاروا السيشن وتضغطوا على الزر بتاع submitting feedback ده we would be very grateful إذا ممكن تملوا لنا الفيدباك فورم حقنا بعد السيشنز لأنه بيساعدنا to gauge ال benefits gained من السيشنز وبرضو it is a requirement للmonitoring and evaluation حق البروجرام حقنا. فدي لما تضغطوا على السبميت فيدباك او تخشوا باللينك ده المفروض تظهر لكم اللوجوز حقت البروجرام دي نفسها and then you can proceed to fill الفيدباك فورم. في الاخر كده اخر سؤال هتبقى مكتوب الايميل حقكم عشان بعدين السيرتيفيكتس تجي عليه ان شاء الله. In the interest of time and because we apologize ان احنا لما مشينا فوق الزمن كتير we're going to have to go over a case-based discussion حقتنا بس I believe that we've gone through multiple scenarios مع دكتور بشير وجات برضه دكتور ضحى شرحتهم لنا very well ف we might have to skip that for today but إن شاء الله next session we'll have enough time to do it. شكرا لكم كثير إنكم انضميتوا لنا we hope you will join us في السيشن الجاية مع دكتورة منى شاكر from the UK. She'll talk to us about how to stop pre-diabetes from becoming diabetes. هي أخصائية بتاعت consultant of diabetes and endocrinology in the United Kingdom. شكرا لكم كثير تاني على انضمامكم لنا بنتأسف كثير على ال technical difficulties والمشاكل اللي حصلت الليلة and we hope to see you next time. زي ما قلت حديكم الريكاب ايميلز حيكون فيها الايميلات حق الدكتورة ضحى والدكتور بشير if anyone has any questions وبرضه you can reach out to either me أمل أو فاطمة إذا عندكم أي أسئلة أو أي حاجة عن البروجرام and thank you so much for being with us ونشوفكم المرة الجاية إن شاء الله. Thank you again.